Well, I think I can help to point in the direction of things we should worry about. I'm not sure how many solutions I can offer, but this notion of personalized medicine, quote unquote, via genomic testing is, we are told, imminently upon us. George Church, who's leading a major research project that involves doing whole genome sequences on many individuals, puts it this way: it hasn't yet produced a revolution, but it's coming. Not a question of if, but when, in the words of a developer. What we have for sure is a growing technical capacity in genome scale tests, and I use that term to refer to tests that interrogate genomic information across the full human genetic complement. We have SNP profiles, or single nucleotide polymorphism profiles, already available direct to consumer, and these are profiles that test individuals for specific gene variants known to be associated with traits or health risks. We have the development of directed SNP profiles, which more clearly fit into conventional medical testing purposes. And a good example is a SNP, a chip test, basically, that tests for known gene variants associated with pharmacogenomic response. That is, gene variants that are associated with either the response to a drug or the risk of adverse side effects associated with a drug. We already have in use in pediatric practice CGH array testing that identifies genetic causes of developmental delay and autism in some cases, or at least genetic contributors to those conditions. And already in research labs, and certainly coming toward us in the clinic very fast, are sequencing technologies that will sequence the exome, all of the coding genes in the human genome, or the whole genome itself. So we do have to think about how is that going to play out. And there's no question that if any of us had our whole genome interrogated, there would potentially be things we would find out that we'd be glad to know and might otherwise not have found out until it was too late. One of them is a condition called multiple endocrine neoplasia, type 2. I offer this just as an example of the kind of benefit that might occur if one had one's genome checked. This is a condition that occurs in 1 in 30,000. It's a condition that causes a particular type of thyroid cancer, medullary thyroid cancer, very high lifetime likelihood, and it's associated with mutations in the RET gene. And our current standard of practice is that if we know someone has a RET mutation, we offer them a prophylactic thyroidectomy, removal of the thyroid, replacement with thyroid hormone supplements, and we now have data following people 5 years out saying, yes, indeed, we are achieving what we want to achieve with this therapy. We're preventing a potentially fatal thyroid cancer. So it's probably a good thing to know that if you have it. And in any person's genome, there may be items of this kind, information of this kind that might be helpful, even though only 1 in 30,000 will have this. Now, I'm sure as lab medicine folks, you're already thinking about the potential for false positive. Even if you have tests with extremely high sensitivity and specificity into 2 or 3 decimals, you do have the potential of false positive results when a prevalence of a disease is this low. And I will just mention that that is, at this point in time, a not fully resolved technical problem. But as we think about how it might play out to have tests that are genome scale, that find out lots of different things about someone's genetic susceptibility, we have to think about the history of genetic testing, and that tells us about significantly different purposes to which we put genetic testing in different clinical contexts. So I think we can generalize that there are three overarching purposes for genetic testing in healthcare. One of them, indeed, is to reduce morbidity, mortality, and the MEN2 example that I just showed you is a good example of that, a way in which a genetic test can find a susceptibility and enable us to take action to prevent death. We don't have a whole lot of genetic tests like those, but we do have some, and they're important. We also have a larger set of genetic tests that enable us to give people useful information that allows them to predict their health status, although these are genetic conditions that don't have a definitive treatment. The information, the prognostic information, may be extremely helpful, not just in healthcare, but in life planning. And then we have the use of genetic testing for reproductive decision making, one of the most prominent uses of genetic testing today. So here's an example. Carrier testing, and followed by prenatal diagnosis when both parents are carriers for the disease Tay-Sachs disease. This is a carrier testing option that's been available since the early 70s. It was one of the first carrier testing options to become available, and it has been taken up by populations at risk. This is a disease that has a higher prevalence and a carrier rate that has a higher prevalence amongst people of Ashkenazi descent and also some French-Canadian populations, such that the incidence of Tay-Sachs disease in populations where this carrier testing is done has dropped by approximately 95%. But clearly that's a very different kind of use of genetic testing than testing for MEN2. And medical genetics practice is very mindful of that difference, mindful of the fact that testing for a reproductive purpose is a very personal choice, and it's certainly a very personal matter whether people who know themselves to be at risk for a genetic disease then choose to undergo prenatal testing and the consideration of a termination of pregnancy. As early as 1975, the American Society of Human Genetics published their statement about a type of counseling that has come to be called non-directive counseling. I think maybe a better term might simply be a type of counseling that acknowledges and supports patient choice. And most importantly, in sharp contrast to most medical practice, is an area of testing where it really is not appropriate for the health provider who's doing the testing to have an opinion about the best course of action. It's the family that should make that choice, and there is no wrong choice for families in this kind of situation. It's worth lingering on that just a moment, because what this counseling standard is trying to get at is the need for a pre-test conversation so that people understand what kind of testing they're getting into, and the presentation of test results in a different way from how we present most test results. Here's an example of the third purpose, the diagnosis prognosis. I'm giving you the example of a boy with vision loss. In fact, the physical examination already gave us the diagnosis, which is retinitis pigmentosa, a degenerative condition of the retina that will cause progressive vision impairment over his lifetime. What genetic testing offers is the ability to interrogate some of the 30 to 40 genes that we know are associated with the condition retinitis pigmentosa. This is a very interesting genetic phenomenon. There are multiple genes associated with retinal degeneration, that is, genes in which a mutation can lead to retinal degeneration, and they follow multiple different modes of inheritance. So we have autosomal dominant, autosomal recessive, and in this case, X-linked recessive. The knowledge that this young boy has X-linked recessive retinitis pigmentosa is important prognostically because, in fact, the course is more predictable and more severe for people with the X-linked recessive form of the condition. It will provide very useful information about education, about career planning, potentially even about where he may choose to live as an adult, so as to be able to access services for vision impaired individuals. it could potentially be linked to other testing in the family if the family chose to use testing, for example, for reproductive purposes. But most importantly, it gives prognostic information that is useful to the individual who got tested. I mentioned 30 to 40 genes. In fact, we have effective tests currently for only about 10 or 12 of those 30 to 40 genes. And one of the great values of genome scale test is that we can anticipate a future in which we will do sequence-based testing of all those genes. And we will be able to identify not only gene variants, mutations within those genes that have already been described as associated with the retinal degeneration, but have the potential also to identify rare or novel variants not previously identified, so that we can potentially identify people that might be missed by less systematic testing. We already use sequence-based tests routinely in another area of practice, and that is in genetic risk assessment to identify cancer risk. I'm showing you a range of families, all of which have some breast cancer present, but obviously in the first family we have a grandmother with breast cancer at age 80. We have a family with ovarian cancer at age 65, and that is kind of intermediate in terms of whether or not genetic risk might be present. In some populations, as many as 30 to 40% of women with ovarian cancer may have a genetic predisposition. And then we have the family where we clearly have breast cancer and ovarian cancer, and we have a very significant risk of an inherited predisposition to breast cancer, and we would use BRCA testing, that is sequence-based testing of the BRCA1 and BRCA2 genes to identify whether or not there is an identifiable genetic predisposition. Why is that useful? It's helpful for people even when they have a family history that that they know to have a significant risk, to determine who within the family has inherited the genetic predisposition, who within the family really does have the very high risk of breast and ovarian cancer, and who therefore would benefit from more aggressive screening procedures, even interventions such as prophylactic oophorectomy. But what we know from more than 10 years of experience with using sequence-based tests for BRCA, of the BRCA genes to identify and assist families, such as I've just shown you, we know that there are three potential outcomes of testing. One, the one we're actually looking for when we initiate testing, is a positive, an identification of a specific disease-associated gene variant in one of those two genes. A negative, which for most people is the more likely result, a normal result. And the third is a gene variant of unknown clinical significance. The proportion of results that come back with this label is slowly going down. When I started doing BRCA testing with patients, we had something like a 10 to 12% likelihood for women of European descent, and that's now down to more like 5 to 6% as novel variants are slowly analyzed, experience is accumulated with multiple families, and the lab is able to determine whether or not it is indeed a deleterious mutation, in which case it will notify the physician who may have ordered that test 3 or 4 years ago, or whether we're now comfortable saying it's normal variation, a benign polymorphism. It's worth noting that the rate of gene variants of unknown significance is substantially higher in most minority populations, reflecting a much slower accumulation of information in those populations. This is a pretty significant burden to the genetic counseling process. A study several years ago, as this phenomenon first became available, surveyed genetic counselors, and what that survey told us was that the majority of genetic counselors mentioned a variant of unknown significance as a possible result in pretest counseling, and that, I have to say, resonates with me as a medical geneticist and my colleagues. We are pretty careful to tell people ahead of time that this may be coming, and that's a difficult thing to explain. Half had actually provided such a result, and of those, the determination was that only about 2/3 of patients truly understood the result. It's a very difficult result to explain, and part of the explanation is, well, this is as far as science has gotten. It hasn't really told us what this variant means. I offer this as a kind of leading example of something that's likely to happen on a much grander scale the more we do sequencing of more genes. And as we move to sequencing of more genes, we also have to think about the implications of penetrance. So penetrance is a phenomenon well described in medical genetics, and I think easily portrayed by the triangle that I am showing you. The bottom line is that when we talk about genetic diseases, we are mostly talking about what we call highly penetrant conditions. That is, conditions that are associated with gene variants, gene changes that are very likely to manifest a phenotypic effect among people who have that gene change in the proper number, depending upon whether it's a recessive or dominant disease. The vast majority of people will get that condition. So for example, amongst people with MEN2, it's somewhere between 95 and 100% as best we can determine. If you have one of those RET mutations, you have a nearly 100% lifetime likelihood that you will have significant clinical manifestations of the disease. With BRCA, we have a little tougher handle getting a firm number. The number we use in counseling is somewhere between 50 and 85%. That's kind of the best handle we can get on it. So it's a little bit further down the scale, but it's still in the highly penetrant category. What we have increasingly is information at the bottom of the triangle. We have information about gene variants that are basically genetic risk factors, gene variants that are associated with moderately increased or moderately decreased likelihoods of disease. And as we think about what we're trying to accomplish with genetic testing, and what we call a real result and what we call an incidental finding, such as a variant of unknown significance, we have to think about how that designation might be filtered through penetrance. It's a lot easier to feel certain about what you're dealing with when you have a highly penetrant gene mutation. Now, that doesn't mean that all gene variants with low penetrance are going to be clinically useful. I just want to give you an example which I would cite as the leading edge of a tremendously exciting area of genomic research, pharmacogenomics. So this is the HLA-B variant 5701 and its ability to predict adverse reactions to the reverse transcriptase inhibitor abacavir. This is a highly effective drug for HIV/AIDS. It's also relatively convenient to take, so it's an attractive therapy to use for both docs and patients. The problem with abacavir is that 2 to 9% of patients develop a skin reaction that can be life-threatening. And so it was very fortuitous that researchers discovered that there was an HLA variant that could predict who was at risk. And you'll notice that the positive predictive value is actually less than 50%. So if you have the variant and you are considering taking abacavir, you have a somewhat greater than 50 odds that you'll do just fine on the drug. But the really important finding here is that the negative predictive value is extremely high. Clearly, another factor here is that alternative therapy is available. So we have a test with only moderate positive predictive value. But when the finding is absent, when the gene variant is not present, we can prescribe the drug with confidence. And we have an alternative that we can offer those people who have a somewhat increased risk of a very bad reaction. And most people find that a pretty acceptable trade-off, and we are now seeing HLA testing prior to abacavir therapy becoming standard of practice. I mentioned this as the leading edge because research now in hypersensitivity reactions suggests that somewhere in the next decade, we're likely to have the potential for a panel of HLA variants that will help us to prescribe a variety of drugs where rare hypersensitivity reactions, the Stephen-Johnson type skin reaction and other similar reactions, are a rare complication. As long as we have an alternative therapy to offer people, that testing will be extremely helpful, even though we're likely to see with other HLA variants what we see with this one, which is a limited positive predictive value. But now, here's the real problem with low penetrance variants. This is data that came out in 2007, right at the beginning of the amazing increase in identification of gene variants associated with common disease that came with the development of techniques for genome-wide association studies. And as we now move to sequencing studies, we're probably going to see another burst identifying even a larger set of rarer mutations. GWAS had primarily the ability to see to identify relatively common mutations. One of the most exciting stories in that early GWAS burst was the story about age-related macular degeneration. What researchers found was that there were several genes, and this study shows the effect of variants in 3 genes that could predict risk for age-related macular degeneration, and some variants predicted a higher risk and some variants predicted a lower risk, and the genes involved vascular development and inflammation, and so offered some interesting clues to pathogenesis. But when we think about using genetic information for risk prediction, which is where the excitement about personal genomics has tended to focus, you get a diagram like the one shown here. This was a diagram that compiled all of the available information at the time about variants from 3 genes that either increased or decreased risk. And what they found was that they could characterize a population of patients across a broad spectrum of risk. 1% of the population was predicted to have a greater than 50% risk of age-related macular degeneration. A somewhat larger percentage fall at the lower end with a significantly decreased risk. My point here is, what's a result and what's an incidental finding if you do testing like this? It's not actually clear. It's actually not clear whether any of these data are clinically useful at the present time because the 2 recommendations we would make to someone at increased risk for age-related macular degeneration are to avoid bright light exposure to the eye and to avoid smoking. But you could imagine, and hopefully we recommend that to everyone, but we could imagine perhaps that if you are in that 1% that has a greater than 50% lifetime risk of age-related macular degeneration, that at a certain age you might benefit from more careful screening, such that you could at least have early therapy as soon as any evidence of macular degeneration occurred. But is that the top 1%, or is it the top 10%, or where do we draw the threshold? And how do we report the results out? What's a meaningful result? Should we be reporting out the low-risk data? Most people, of course, are going to be more or less average. What do we tell them? How much emphasis do we put on being 20% above average or 20% below average? Low penetrance gene variants, of which we have many now and a growing number into the future, will cause us to have to think about these thresholds in many different testing situations. And this is particularly a challenge when we think about using testing for screening. I'm giving you a standard definition of screening. The key issue here is that when we talk about screening, we are talking about people who don't have disease, who don't know themselves to have disease, who feel okay, and we're doing a test in order to find things that they don't know about. And why are we doing that? Well, we're doing it because we want to take action. And the rhetoric around personal genomics, that revolution that George Church is talking about, is a revolution that assumes that we can use broad-scale genomic information to accomplish this purpose. It assumes that we can identify early disease, or better yet, risk, and take action, and as a result, improve outcome. And that's why the issue of what do we tell people about their age-related macular degeneration associated gene variants becomes crucial. What exactly do we tell people, and what actions can we then expedite or facilitate to enable them to maintain their visual acuity? And I don't, I think, need to stress, I'm sure you're all aware, that taking action means we've got to know what actions and what level of evidence we have that we're actually making a difference, with, I think, a conventional understanding that if you're taking action in healthy people, you want to be pretty certain that you're going to produce a net benefit. So genetics has some very robust examples of genetic screening, but these are predominantly limited to high penetrance disorders, and they are also focused particularly on high penetrance disorders that have a particular time urgency. We have newborn screening because of people's understanding about the opportunity for intervening with the disease phenylketonuria. This is not a common condition, more common than MEN2, somewhere around 1 in 12,000 to 1 in 15,000 in the population. But over a 30-year period between the 1930s and the 1960s, people slowly put together a lot of information and kind of figured out what phenylketonuria was. It's an autosomal recessive condition. In its most common form, it involves deficit in an enzyme that processes phenylalanine, and it can be addressed with diet. It's a condition which, if untreated, leads to very significant cognitive impairment as well as other neurologic difficulties. But with a diet, individuals can avoid those complications. The diet has to start early, so there's a time urgency, and that is what led to the creation of what is now a very large public health infrastructure in all states, one that has produced very significant benefit. But that benefit is complex. It certainly took some time to figure out exactly who had phenylketonuria and what kind of testing pathway was going to be robust to distinguish children with PKU who needed the diet versus those who just had a physiologic elevation of phenylalanine. It took years of research to determine that kids need to stay on the diet. People with PKU need to stay on the diet through their lives, that women with PKU have a very significant risk of having children with microcephaly if they don't have a well-controlled diet during pregnancy. So achieving all of the benefits of this early detection involved a considerable amount of research following the institution for newborn screening. What we have as a result of having this infrastructure is now a growing number of conditions that we have added to the newborn screening panel. And many of these conditions are not quite as time urgent or with quite as dire a need for therapy prior to clinical manifestations as PKU. Nevertheless, because we have the screening infrastructure, we're able to provide benefit. One of the examples of a condition that's been added relatively recently to the newborn screening panel is cystic fibrosis. Cystic fibrosis is a condition As I'm sure you're aware, it's a condition that is also autosomal recessive. It's a condition that involves progressive loss of lung function associated with recurrent infections of the lungs and thick mucus. Individuals with cystic fibrosis also typically have abnormal digestion. They don't have the full digestive enzyme complement, so they need help with that. Otherwise can experience malnourishment. So there are a variety of ways in which cystic fibrosis can be a very severe disease, and treatment makes a huge difference. The life expectancy of people with cystic fibrosis has gone over a 30-year period from something like 6 to 8 to now approaching 40. So we like to find kids with CF, and we like to offer them treatment. And there is data, there have been data from a randomized trial that say if you find those kids early, you can have better nutritional outcomes on average, which is the strong rationale for newborn screening for cystic fibrosis. But one of the interesting outcomes of newborn screening for cystic fibrosis has been the delineation of a new syndrome. This is a syndrome called cystic fibrosis transmembrane conductance regulator-related metabolic syndrome, or CRMS. This is a new condition that has come forward as a result of newborn screening because these are individuals who have a positive initial screen, which is a form of trypsinogen that is used for the initial screen, and a normal sweat chloride. I note that sweat chloride has traditionally been considered to be the gold standard for diagnosis of cystic fibrosis, but then in their follow-up confirmatory testing after their initial screen, they've been noted to have 1 or 2 mutations in the CFTR gene, at least one of which is not clearly CF causing. Well, there's a whole lot of information behind that. One piece of information is that once we figured out the gene involved with cystic fibrosis, the CFTR gene, and began to look for gene changes associated with cystic fibrosis, we found many, over 1,000, but we also found some, we found many, and many with a variety of different levels of functional impairment. And a certain number of mutations in the CFTR gene are found both in people with CF and in people without CF. There are mutations that are clearly associated either with mild presentation or potentially with no disease. And so what do you do with a kid that's come through the newborn screening program and has this kind of profile? This isn't the kid we were looking for. This isn't why we do CF newborn screening, but this is a child that falls into an ambiguous category. And so what happens is that we have to figure out what to tell the parents about the kid's prospects, and we have to figure out what kind of care to offer. The paper I'm citing here, it reflects the findings, the expert opinion of a group of experts who came together, and one of the things they concluded is we really don't know enough about the prospects of these kids to be comfortable saying, you're fine, we don't need to see you anymore, and that therefore, erring on the side of caution, we would like to have these kids come to CF centers and be followed on a regular basis. And what this paper is about is basically the protocol guiding clinicians. Now, we have to step back and say, was this a good thing or a bad thing? It is not at all clear. It is very likely that many of these kids will do fine. It's also possible that some of these kids may ultimately have significant disease, perhaps with a later onset. 10, 15, or 20 years from now, we're going to know a lot more about what this entity is, and possibly it's going to ultimately be some sort of binary distribution where we can say X percentage of these kids with the following findings are fine, and this other Y% actually do have a mild form of CF that requires therapy. We don't know yet, but in the process of screening, we have found these kids, we need to respond, and I offer this as representative of the kind of situation that we will be facing more and more as we have more and more genetic information. That was an experience that came out of screening a high penetrance condition. What happens when we screen for low penetrance tests that assess for common disease risk? And I offer you a quote from 5 years ago by, not coincidentally, a quote that appeared on a business page and came from the CEO of a company that was offering tests for sale. What the CEO said was, it's terribly important to know if you have a gene variant that they had discovered that gives you a relative risk of 1.5 of developing type 2 diabetes, because it gives you an added incentive to exercise and eat right. So here is a proposal for the clinical utility of low penetrance gene variants, and in fact a proposal for screening. So what about that? Well, in fact, we know that eating right and exercising probably has far more to do with who you eat with and who you exercise with than it has to do with your genetic makeup. So the proposal that this would affect behavior was questionable, but the discussion of whether or not information of this sort is useful or helpful, or under what circumstances it might be helpful, is a conversation that has legs and is going on today. It's worth noting that as we have this conversation, we also have the problem of what actually is meaningful data. So one could say, does a relative risk of 1.5 for type 2 diabetes even rise to the level of meaning? It's a statistically meaningful result, but is it a clinically meaningful result? I want to show you this other example just to make the point that we're really not sure how to communicate about these kinds of risks. This was an article written by a reporter after SNP profiling type tests became available direct to consumer. And the reporter, there have been many stories like this. This was one of those stories where a reporter got 2 different tests from 2 different manufacturers, and he is complaining, basically. The news in his story is that these were inconsistent. So one of them gave him a risk for age-related macular degeneration that was 20% lower than average, and the other 62% higher, and similarly lower and higher risks for coronary heart disease. And I'm sure it's obvious to you that the fundamental problem here is that we're talking about differences that are clustering around the mean. In fact, one company using one set of data clustered a little below the mean in estimating the risk, and the other company maybe used a different set of data and clustered a little above the mean. He's about average, in other words, for both of these risks. And that's really the message he needed to hear. You're about average. And we really don't have different recommendations for him based on his being a little below or a little above the mean. We certainly don't want him to be casual about things like not smoking or eating healthy because he's a little below the mean. So I think this again gets back to the same threshold problem that I posed for you with the figure on age-related macular degeneration. What information is useful, and how do we present it to people? I personally have no objection to people buying tests of this sort over the counter via the internet. Some people want that kind of information, but I think we do have a responsibility to make sure that the information they get is sensible and meaningful. And a report that proposes that it is significant that your relative risk of coronary heart disease is estimated to be 1.06 of normal is, to my mind, not achieving that. So it's really a dual challenge. Challenge one is to figure out what thresholds would be meaningful, and they're going to be different for different disease risks because it depends upon what you're going to do about it. But then also to assist developers of this kind in providing responsible messages, meaningful messages that individuals can use. And this is particularly important because there is in our society at least a sector that is extremely interested in getting information. So in response to Kari Stephenson's announcement about a diabetes variant associated with a 1.5-fold increased risk of diabetes, a science writer in the New York Times reflected upon the meaning of such results from her personal perspective, which included that she has a family history of type 2 diabetes. She actually reflects that she's not sure the genetic test, if she had it and were positive, would change anything, since she already has a positive family history, and statistical analysis backs her up that actually the test would not add anything meaningful to the estimate of risk. But the more important comment that she makes is about her interest in getting information, but also her interest in deciding. I'm not sure what I'd do with the results or whether they would mean anything for my future, but I'd like the information and the right to decide for myself whether to act on it. So added to the challenge of figuring out what thresholds are clinically significant and how to explain data that we regard as medically meaningful or not medically meaningful, we also have to consider a potential strong consumer interest in information, perhaps even information that would not rise to our standard of clinically meaningful. And how do we negotiate that? How do we have the right kind of conversations about that? Who decides what's actionable or what's a benefit? This is one of my favorite quotes from Robert Veitch, a philosopher, who says, "It's unrealistic to expect physicians to be able to determine what will benefit their patients. Either they limit their attention to medical well-being or they strive for total well-being, which takes them well beyond their expertise." Now, he's throwing out a gauntlet there, and I think we have to take it seriously, meaning that we have to take seriously what our charge is. Our charge is to inform people about the medical implications of information, and that will be a big challenge with the genetic information coming our way. It may well be that people have interests in acquiring genetic risk information that's unrelated to coming to healthcare centers for care. And I think we have to be concerned as health professionals that information available to them is accurate and enables them to make decisions. But we may need to distinguish between appropriate procedures for using genetic information medically and reasonably safe procedures when that information is available direct to a consumer. Here's an example. A very interesting study has been done in which adult children of people with Alzheimer's disease have been offered the opportunity for ApoE testing to determine whether or not they have the ApoE variant that's associated with increased risk of Alzheimer's disease. From a medical perspective, this particular assessment is not useful. There is no preventive therapy that we can offer to people with ApoE4. It doesn't even have sufficient predictive value to assist in the diagnosis of Alzheimer's disease in someone suspected of having Alzheimer's disease. As I'm sure you're well aware, other physiologic tests are now being developed that may have more predictive value for that purpose. But what this particular study revealed was that people who participated in the study, undoubtedly a biased sample of individuals, a relatively small study of people that chose to pursue ApoE4 testing, knowing that a parent had Alzheimer's disease, knowing that it would give them additional information about their own future risk. What this study shows is that some of them, those who got the positive result, used that information in making decisions about long-term care insurance purchasing. So this information was distinctly useful for a personal decision. It wasn't what we would call information with clinical utility. It didn't assist healthcare providers to do their job better. But it did provide information that for these individuals was presumably a reasonable trade-off. They were willing to accept the risk information in order to be able to make this kind of decision. Now, the problem, and it is a significant problem for us in healthcare, is that the promises of direct-to-consumer personal genomics are quite a bit more dramatic than that. I'm citing from one of the direct-to-consumer companies, Navigenics. Our goal is to empower you with genetic insights to help you improve your health through disease prevention, early detection, and medical choices tailored to you. Very clearly promoting the notion of a medical intervention, a health-related intervention that is basically a screening goal. We are going to test you, we are going to find your risks, you're going to be able to take action and improve your health. So we're now beginning to have outcome data. This is a very recently published paper in the New England Journal. Scripps made an arrangement with Navigenics where they offered a discount price to people receiving care there for the Navigenics panel. And as you can see, more than 3,500 people chose to purchase the discounted panel, and something like 2/3 of them completed a follow-up questionnaire between 5 and 6 months after testing. And this is, of course, self-report data, but what this self-report data says is basically nothing much changed. They got their data, didn't make them anxious, didn't make them change their exercise or their dietary patterns, didn't make them increase their medical screening. That's only 5 to 6 months. It'll be interesting to see ongoing data. The good news is that whatever worries we might have about what is called the cascade effects of screening may not be a concern with these low penetrance mutations associated with common disease risk. At least those data suggest perhaps not a worry. And so perhaps if they come through as incidental findings, we shouldn't be overly concerned about them. On the other hand, they're not doing much good either. And that is important because it's an important body of data to follow, because as we think about using genomic information to screen people, we do have to think about potential harms. As these authors say, every adverse outcome of screening is iatrogenic and entirely preventable by not screening. And so knowing that people don't take on extra medical care, if that indeed plays out, will actually be a very useful, reassuring datum to say, yes, this is a safe consumer product. Knowing that people don't change their behavior as a result of these kinds of risk information tests may also tell us that they don't have much place in healthcare. I think it's still early days, but this kind of information is extremely important and may help us to sort out which information we can label as a true medical result and which information we may want to say is incidental findings, not of much interest clinically. And I want to wrap up by talking about the clinical interpretation of a whole genome sequence. So direct-to-consumer tests are SNP profiles. They are basically chip-based tests that test for gene variants about which there is some data to enable us to interpret exactly what kind of risks they might be associated with. But a whole genome sequence is an effort to sequence everything. And in Lancet last May, researchers from Stanford reported the results of an attempt to identify the clinical significance of one individual's whole genome sequence. And this is the individual, a 40-year-old man, healthy, who has a significant family history of cardiovascular disease. So in particular, he has a family history of coronary artery disease, of abdominal aneurysm. There's a first cousin with at least mild signs of cardiomyopathy. And he has, this first cousin's son died of sudden cardiac death at age 19. But the individual himself is healthy. He has participated in the Harvard study in which several individuals are having whole genome sequences done. And as he and colleagues talked about it at Stanford, they decided it would be a useful exercise to try and go through his whole genome sequence and compare it to what was known about him clinically in order to see what's involved in making sense of genome sequence. And I think it's also a useful exercise to ask ourselves what's going to be involved for us as a healthcare community in trying to grapple with this kind of information as it comes our way. Well, let me give you just a brief overview of their analysis. First of all, what they had to deal with in this whole genome sequence was 2.6 million single nucleotide polymorphisms, that is, areas of variation, as well as 752 copy number variants. So the first thing we can say about anybody's whole genome sequence is it's an overwhelming amount of information, and we're not going to be able to use this clinically in any kind of realistic scenario unless we create protocols for figuring out how to make sense of the data. And this paper, I think, is a very interesting first step in asking what would be involved in doing that. Now, they set themselves certain rules. They didn't try, and it would have probably been unrealistic to try to make sense of absolutely everything or absolutely every single one of the 2.6 million SNPs. So they decided to focus on specific genes. Those were genes known to be associated with Mendelian diseases, on novel mutations, mutations that hadn't been described before, on variants that were known to be associated with drug response, and on specific variants known to be associated with common diseases. They did something very interesting in their common disease risk analysis, and that was they did a comprehensive assessment of the individual's risk for 55 common diseases based on conventional risk factors. So the conventional risk factors certainly did include family history, and we know he has a family history of heart disease, for example, but also included review of his lifestyle risk factors, physical exam, and some basic cardiac measurements. What they argued was if you get a whole swath of variant data associated with common disease risk for an individual, the only way to make sense of it clinically is to figure out what their pretest risk is, and then ask how much did risk change as a result of the variants we found on the genome scan. So that's what they did, and they basically created a protocol to do that. Now, in order to do the analysis that they undertook, they had to use multiple databases, more than 10 databases as best I can calculate going through the paper. They also did independent literature searching and developed algorithms to estimate the functional effect of novel variants that they were identifying. This is what a colleague of mine laughingly calls the future of the $1,000 genome billion-dollar annotation problem. So it was a huge undertaking. I think it points us in the direction of the research agenda if, in fact, we are going to have $1,000 genomes and want to bring them into clinic. Two ifs. I understand the $1,000 genome is a sure thing, but the bringing it into clinic, I think, is a little more uncertain. Bottom line, they did find rare variants that were potentially associated with cardiovascular risk in 3 genes known to be associated with cardiac disease. Bear in mind, he had a family history of significant cardiac disease. One could have approached that particular part of the risk assessment by sequencing specific genes as opposed to doing the whole genome and getting the same information. They did also identify a number of other Mendelian traits. For the most part, they were carrier states. That is, a gene variant in 1 of 2 chromosomes for a disease that's known to be autosomal recessive. They also found many pharmacogenetic variants, in fact 63 in his genome, that have some data behind them saying that they are associated with a drug response, many of those not necessarily clinically validated, but where we can show by laboratory study that there is some relationship between the variant and how someone responds to the drug, and 6 novel variants that might also be significant. And here's a very interesting component. As I mentioned, they did a pre-test risk assessment actually for many, many diseases, more than 55, but for 55 they could assess meaningfully pre-test and post-test risk, and they found that risk changed in only 8 of 55 common disease risks. Some went down a little, some went up a little. Even where risk changed, the absolute risk level didn't change all that much in all of them. So for example, he was found to have overall an increased risk, a moderately increased risk for age-related macular degeneration, but the absolute risk was low enough for him that change wasn't a huge change. And of course, this is early days. This interpretation was done at a time where much of the data in the genome are uninterpretable. But I think it points us to the direction that we are facing. As John Eisenberg said more than 10 years ago, technology is rarely inherently good or bad, always or never useful. The challenge is to figure out when, who, under what circumstances will information be helpful. And I think we have a very tough problem with this potential to rapidly generate huge amounts of genomic information in terms of solving that problem. If we think about the road ahead, more genome scale testing is probably going to be happening. So data is going to be generated with multiple potential purposes. We are entering an era where there's a great deal of ambiguity about what constitutes an incidental finding. Why did we do testing? What are we looking for? And much data that's difficult to interpret or of questionable clinical use. We're going to have to think very carefully about what kind of information do people need before testing and after testing. There is an urgent need for research that looks at interactions between genotype and environment in order to help us interpret a lot of the data. And I would suggest that one of the challenges we must take up within the healthcare system is to develop protocols for censoring data. There are going to be data that are meaningless, useful, or harmful, and we have to figure out what those are. I'm not suggesting a paternalistic approach. I think it may be very reasonable to engage patients in that conversation as well, but I think we are going to have to take that challenge up, and it's going to be a long road. Thanks very much.